Sir. Okay, well, I'm going to talk about myself. My favorite topic. This is some of the places I've been invited to talk around the world, and so it's been my pleasure to talk about my MGB now 25 years later. So I humbly thank you for being here. I'm honored to be here with my brothers and sisters in India who have participated with me in bringing the MGB to the world, and so I'm honored and pleased to be with you. I like a famous quote. I remind myself and all of you, those who do not remember the past are condemned to repeat it. Let us be wise in realizing that many surgeons have been wrong about their opinions in the past. So let us be open and maybe learn from our mistakes in the past. And so the MGB, which has been criticized for 1/4 of a century, 25 years, is nothing more than routine general surgery. For over 100 years, the Colles gastroplasty and a Billroth II gastrojejunostomy has been part of the general surgeon's armamentarium, and people who are critical or confused or opposed to it misunderstand that it's nothing more than regular general surgery. And I celebrate that my own country, only 25 years later, has approved the MGB in the United States. But they are still far behind India, my second home. In brief, the mini gastric bypass first done in 1997, and my series was over 6,000 patients back in 2011. And we now have more than 10-year data. Dr. Kular and I are publishing some papers on that today. There are multiple centers and randomized controlled trials, and there's nothing special to an MGB. This is a Colles gastroplasty, and the gastric bypass is nothing more than a Billroth II gastrojejunostomy. And so many people have reported good results, but I think the most worrisome thing is there are good, honorable surgeons who produce bad results. And the bad results could be because maybe the surgery is bad. I would like to argue that the explanation of poor results is not understanding some of the details of how the surgery is to be done well, how to manage the post-operative patients, diet, and other tips and tricks. And I won't have time to go through that, but I would say my email, my phone is constantly available. I am honored to talk with surgeons all around the world about difficult patients or just to ask questions. So I honor you for taking time and effort to learn how to do the surgery better. But also, you're welcome to call me anytime, day or night. I'm happy to help. Okay, the Billroth II is over 100 years old. It's been done since the 1890s. In the United States in 2007, these are old slides, there are 16,000 Billroth IIs done. It's done for trauma and ulcers and gastric cancer. Why would the bariatric surgeons fear it? Listen to me, I have been criticized now for 20-some years. They criticize me, though, for some things I think you will laugh about. In the olden days, many years ago, we were told we had to do bariatric surgery and remove the gallbladder. And I did not do that, and they laughed and criticized me. They said that if you did a Roux-en-Y, that the Roux limb had to be retrocolic and retrogastric. And I did not do that, and I was criticized. They said the MGB would cause gastric cancer because it was nothing more than the old Mason loop gastric bypass. And of course, they were wrong. They said that the Billroth II, even though it's done all the time, they said that is going to cause cancer, and that was wrong. They said that the pouch was too big because everyone taught in those days, and still some today, that the Roux pouch must be tiny. And the gastrojejunostomy, in many surgeons' hands, even today, they make a tiny little gastrojejunostomy, which I did not. And they said, your surgery will not be successful. Patients will not lose weight. And here is something I think you'll find amusing, that 20 years ago, I was criticized by bariatric surgeons in the US in particular, because they said Dr. Rutledge is bad because he uses email and he has a website. So, I have only a few minutes. I'm told I can only speak 15 minutes. I've already tested this with Dr. Arun Prasad, and it went for 12 minutes, and so I'll finish early. I hope to answer any questions. This is a brief history lesson on the Billroth II because there's nothing more to the MGB than a Billroth II. It's a good operation when done well, but I think when people misunderstand it, when they make a tight, narrow pouch, a tight gastrojejunectomy, a twisted, narrow, or ischemic gastrojejunectomy, reflux and other complications can occur, and I honor you and respect you for coming today to learn more to do the operation well. Many bariatric surgeons, I would say, do not understand basic general surgery. The Billroth 2 is a good operation, and the Billroth 2 alone, done for ulcer disease and cancer, has been shown that it by itself, with a short bypass, improves diabetes, protects against subsequent cardiovascular disease and stroke, and I'll just give you a little bit of information. Many bariatric surgeons don't understand basic general surgery. This was true 25 years ago, and my opinion is it's still true today. And I honor you again, as I say, for trying to learn more. Here's an example from the entire nation of Taiwan. In a comparison of 27,000 patients, they found that those ulcer patients matched for other measures, that if they had an ulcer with an antrectomy and Billroth 2, they had fewer strokes. It protected against ischemic stroke. Just a Billroth 2, not an MGB, just a Billroth 2 with a short BP limb. They also found that similar patients had a lower risk of heart disease and death, just with a Billroth 2, not with a long bypass and not with a narrow gastric pouch. It's that only. That's all that was necessary. Imagine. They found that coronary heart disease, 22% less based on just a Billroth 2. That's all. Associate 2017. Not only that, they found that diabetes was 50% lower, 1/2 relative risk, 1/2 as much if they had nothing else. They were exactly the same patients, but they had a Billroth 2 for an ulcer. Nationwide population-based data. There's more, but I'll skip on. Why did bariatric surgeons get confused? Well, because my Billroth 2 was similar to a failed operation known as the Mason loop. That's the history. And still many surgeons are confused about this misunderstanding. This is not done by general surgeon. It is a bad operation. He is a great man, great surgeon, bad operation. I'm an average man, but this is a good operation. Here's what happens to some operations. Remember the lap band? What's happening to citations? The lap band's going away. The MGB has been under attack by other surgeons for a long time, but it's growing. Let's show you some examples. It's time to see that the MGB's recognition is here. And what we say, those who do not learn from the past must repeat the past. Where did this all begin? Dr. Rutledge, I was a trauma surgeon for 20 years. I was a professor of surgery. In 1997, on a Thursday night, in September, a drug dealer was shot in the belly 6 times with a high-powered .357 Magnum. 9 o'clock that night, on a Thursday night, I took him to emergency surgery, and we found gunshot wounds to the stomach, the pancreas, and multiple loops of small bowel. I did a standard general surgery, nothing clever, nothing smart. I just cut out the distal stomach, the distal pancreatectomy and splenectomy, and I reanastomosed the patient with basic general surgery. This is not new. I am not smart. This is just basic general surgery. In those days, in 1997, I was one of the first surgeons in Earth to do laparoscopic gastric bypass. The laparoscopic gastric bypass in those days, as I said, was difficult and dangerous, and I would even say deadly. After finishing this case at 2 or 3 o'clock in the morning, I had another case the next morning. A young woman who was a surgical nurse that I had worked with who was morbidly obese, and I told her, this operation I did last night seems to me to be better than the Roux-en-Y. And I thought I would do anticolic, and I would just do a callus gastroplasty, which is standard general surgery. She approved that, and the surgery went well. The MGB is nothing special. It is routine general surgery. The Billroth 2 has been shown for almost 200 years. It's a good, safe operation unless it's done wrong. General surgeons know how to use the Billroth tube, but many bariatric surgeons are confused, uninformed, and fear the Billroth tube. No, yes, no, yes. And some other tricks and traps are available here. But let's summarize. I don't want to talk too long. I know you have other very excellent presenters, but basically the way to think of the MGB, it's a short, simple, easy operation that can be done without technically demanding efforts as long as you're well trained. It's nothing more than the original antrectomy and gastrojejunostomy. It adds the simple extension of the esophagus procedure, that is the colus gastroplasty, and it's designed to be non-obstructive restriction. There's a lot behind that. And it's an anticolic, not a retrocolic or retrogastric, anticolic Billroth 2 gastrojejunostomy. And uniquely amongst all surgery, no other surgery routinely tailors the bypass limb length to the patient. That's an obvious addition, and it's very simple, and it makes perfect sense, although you have to understand it. And so I would conclude by saying, I thank you for the invitation. I would argue the mini gastric bypass is simple. In my hands, the standard non-super obese patient is simple with a mean operating time of 20 to 30 minutes. It's elegant because it's beautiful. There's no dissection of the EG junction. It's effective with excellent to maybe the best possible total weight loss. It's durable. We now have patients of mine you can talk to directly online on my Facebook page. You can talk to 20-year MGB patients. It's powerful. It's uniquely tailored to anyone from the thin diabetic to the super obese patient. Plus, it's easily revisable and reversible, uniquely amongst the other forms of bariatric surgery. So go ahead and thank you again for the opportunity to talk with you today. I'll go ahead and stop sharing my screen and tell you how much I've enjoyed talking about this, and I'd be happy to be available to anyone at any time and answer questions you have.
Good. What name software? Oh. Right. Hi, can you see me?
Sir, I can barely see you. You're in the dark, but I know who you are. Hello, my brother.
Hi, thank you. Thank you very much for joining us. And it's indeed a great privilege and honor to have you here to start this session. And great to see you. So we have a group of surgeons here who are going to ask their how many are going bariatric surgery. So we have about 20% who are in my bariatric surgery. The rest plan to start bariatric surgery? Yes. So everyone saying yeah. And once people who are doing bariatric sport procedure and going to see surgery? Yes. Anybody doing bypass? No. So we have a group of people here who are 20% are doing ski gastrectomy, the remaining 80% plan to start bariatric surgery as well. So I would like to ask you is that for people who are doing ski, for them to start doing an MGB, what kind of difficulties can they face?
Well, I think that what we see is what we call the MGB paradox. And you're probably familiar with this, but if you look in the medical literature or you talk directly to surgeons, what we find is many surgeons report very high rates of reflux, very high rates of malnutrition, very high rates of other complications. On the other hand, there are other surgeons who have excellent results. And so there is this, I think, confusion, and I think I can explain it. We recently have completed a study of a meta-analysis of more than 29,000 MGB patients from 12 different studies. And what we found is the average meta-analysis incidence of reflux in all MGB patients, for example, is around 2.5%. But we also found that there was a group of surgeons, a group of programs with high rates of reflux, bad outcomes. And we found another group with very low rates. And it's not a perfect correlation, but what we found is the people who had higher volume had better outcomes. And so if you just think about any surgical procedure, if you're new, you're probably not as skilled as your professor who's teaching you how to do it, who's done it for years. And so what we think is just what you're doing there, Dr. Prasad, is very, very important. We think the MGB can be done badly. And just to give you one example, there is a study from several hospitals in Australia, and they said 1 out of every 10 of their, what they called single anastomosis gastric bypass, or mini gastric bypass, or OAGB, but they called it single anastomosis in Australia. And they said 1 out of every 10 had to be reoperated on, not just had reflux, but reflux so crippling they had to operate, 1 out of every 10. And I think, I don't know what your numbers are, but we know most of the well-educated, well-trained, high-quality, high-volume bariatric surgeons doing MGB see it 10 times lower. That is in the 1% range, and very few needing to be reoperated on, Mario Musella and others. What that tells me is the new group of surgeons, go ahead and cut your teeth on doing the simpler operation of sleeve. That's okay. On the other hand, know that you could do an even easier operation like the lap band. On the other hand, the lap band is no more, I think. There is a reason for that. And the sleeve is a high rate of failure. The numbers that we see from your own data in India shows that 1 out of every 3 is going to have significant weight regain. If you think you're doing a good practice, if you think you will bring more patients back by becoming a famous sleeve surgeon, I would just warn you. Remember, we have data from Israel. And I don't know, should I stop for a second and show the data of how sleeve has fallen in Israel for a moment?
Yes, please go.
Okay, 1 second. I will just have to change my...
Sure. While you're looking at that, my basic question was that people who are doing sleeve have got used to a particular way of stapling and going up towards the end of S. When it comes to an MGB, again, some part of the procedure while creating a pouch is quite similar to doing a sleeve gastrectomy. So my question was, technically, what challenges or what differences these surgeons should be looking at when switching over from the sleeve gastrectomy to an MGB?
Good. I have some drawings and some cartoons that I would like to answer by showing that, if I could. Is that it? Then so I have 2 things I could show you. One is the drawings that you might find valuable to answer that question. The other is what's happened in Israel with the frequency of doing the sleeve. Do you have a preference or both, or what should I do, sir?
Let's go to the drawings because it will get more basic.
All right. 1 second. I will be right back with you.
While you're looking for that, and
yes,
it's good to be prepared for my second question.
Okay.
The remaining 80% who are here who are planning to start bariatric surgery. For them, would you suggest that you do X number of sleeve gastrectomies before you graduate to MGB? Or would you suggest that you can go straight ahead and start with an MGB? I guess most people would want to move all this answer to this question.
Yeah, I think that you suggest a good point, which is that the more you learn ahead of time, I'd rather you make your mistakes on the sleeve patients. Hang on, let me get my picture. I'll be up just 1 minute. You can go ahead and talk. It'll take me just a moment. Sorry.
Repeat checking.
Okay. Yeah.
Yes, it is. One of the other questions is,
Is the orientation on there. So on the cartoon, I've seen two different images. One showing that that's the stomach without bringing up the public intestine goes that way. That you now bring it and your intestine goes.
I actually, that's one question I answered in my talk when I talk to you about the steps of LGB. So those technical details I will explain to you in my talk.
So the morning fast is just to stay old animals. See, it is very important to understand that is so that is an important factor of Bibles, books here, and then it has basically using that on all is big concept.
No, so we are not leaving the okay. We have to back to the diagrams here. Dr. Rutledge, please carry.
Okay, so basically, I would say these are drawings by a surgeon who was a friend of mine and did it, I think, beautifully. And so there are a lot of technical questions, and I won't go through everything, but I think I got the question that you asked was specifically about the pouch and the sleeve. Dr. Prasad?
Yes.
You asked specifically about the sleeve pouch versus the MGB pouch. Is that true? Okay, so I'm going to talk about, this is the MGB pouch. You can see this okay?
Yes, sir.
Okay, so here's your bougie, and the tip of the pouch is very important. In other words, many surgeons operate between the legs, and their instruments come like this instrument here from below. So when they create their pouch, sometimes they make the mistake of the instrument coming this way, and so they create the error of what's called the bird's beak. The bird's beak. In other words, if you could imagine that the instrument comes this way, then you would have a long, narrow beak of the tip. And that narrow beak then has blood supply here, but it narrows it. So when the gastrojejunostomy is performed, it gets shorter. And if you foreshorten the pouch, then you begin to make it move up towards the EG junction, and then you get your patient having more reflux. And you don't want reflux, obviously. So what we want is a long pouch, and we want a wide tip. And so we'll look at that on the next one. So here's what we want to look at. So the staple gun, we often recommend that an extra port be used up here to come down like this. And so we'll go back if I can. Let's see here. Yeah, see this, imagine this staple gun is hard for the sleeve surgeon to understand. They have usually two hands, of course, and their staple gun, you see how this white line here? That's the error of a sleeve surgeon coming to MGB. Then they have a narrow tip, we call it the bird's beak, and instead what we want is this, and then across like this. And so what we want is this big wide tip, because we don't want a stricture. And we're also going to talk about ischemia. So we want this big wide tip here, and that's very different. The other thing is, I don't know what the latest is, but sleeve surgeons used to argue in the beginning it was critically important to dissect the fundus. The fundus need to be resected. And of course, I think now the data is pretty clear that's not the case. But for the MGB, what's the most deadly complication of the sleeve or the MGB? A leak at the esophagus, yes?
Yes.
Okay, so don't go there. Stay lateral. We do not need you to dissect near the EG junction. We do not need you to dissect in the area of the hiatus. We want you to leave the esophageal sling, and we want this wide open so it's non-obstructive, and we want the gastrojejunostomy to be wide so there's not obstruction. And then we want to teach the patient to eat differently with a high-fiber, healthy diet. But reflux occurs if you stricture this area or damage this area or make a narrow pouch or an obstructive pouch or the gastrojejunostomy. So oftentimes the ideal sleeve, which is tight and narrow because it's primarily restrictive, right?
Okay. So I think that answers your question.
Okay.
Great. I think that makes it quite clear, and I will be showing you also the steps in the
Yes, sir.
videos subsequently. How has the MGB progressed over the years. I don't know about this acceptance, which had been gradually getting better and better. And in India, we started this procedure quite some time ago with your guidance, with you going to all the centers individually. I remember you coming to my center and helping me do the first rerouting MGB in the world. And we have been having great results. Gradually, we have seen that more and more countries have accepted, including the United States, and they have so. And so, how pleased are you with the progress, and what future do you see of MGB in pediatric surgery?
Well, I'm invited to give a strong, harsh talk in November. So you may know the IBC, the International Bariatric Club, with Dr. Harris Khwaja.
In Oxford on IBC.
Yeah, so I'm invited to give a talk there. And so I'm very honored, but he has given me the responsibility of giving a talk that will make everyone angry. The idea of my talk is I'm supposed to say, the MGB is the best operation and will soon dominate all others. So I, of course, accepted that request.
Doubts on that statement?
Pardon?
You have any doubts on that statement?
I think all I would say is right at this moment, I have some simple comments. One is that the Roux-en-Y is a good operation, but it's more complex and it's difficult to reverse. And some of its ideas of causing a tight, narrow pouch and a tight, narrow gastric jejunostomy and the Roux limb don't seem to be that valuable to me. The sleeve is very popular, but the lap band was very popular. So I'm happy if surgeons do that. My bias is the nice thing about a failed sleeve is we can convert it to a good operation that like the MGB. And the other thing is that the MGB does have maybe more technical demands, but my bias is that I would prefer that surgeons who do not wish to become skilled at the MGB do not do the MGB because they can make the MGB look bad. What we think is that if you compare operative time, patient complications, patient outcomes, that by every measure, it's a short, simple operation. It's reversible and revisable, so that if you have too little weight loss, you can fix that. If you have too much weight loss, it's easy to fix that. Revisions take 30 minutes. There are a lot of advantages the way we see it, but of course I'm biased. But what we're seeing around the world and what your country has shown in a leadership position is that even grumpy old America has identified that the MGB is now one of the best operations. And my bias is, it's hard to be critical. We have seen some surgeons with bad outcomes and report bad outcomes, but they're the minority, and many of them, according to our recent survey, seem to have maybe less skill and less education, and there are ways to avoid bad outcomes by learning more about it, just what you're going to do with the group today.
Thank you. Thank you very much, Robert, and we look forward to meeting you.